I understand now that this is the first lecture on something that is focused on ECMO. And it has been a very good idea. I'm a fan of ECMO. But anyway, it's not exactly something talking about only about therapeutic, but the problem is that we do not know what the right PO2 is, because you young people can go up to the mountains, top of the mountains. Peter Suter goes top of the mountains, even if he's not very young. But you know that you can go to top of Mount Everest, and PO2 there is approximately 30 millimeters of mercury, and come back and tell stories. But this is a paper of a few years ago that shows that at 8,000 meters, partial oxygen pressure in average in people was lower than 30 millimeters of mercury, and that arterial oxygen saturation was kind of low. Let's look at the numbers, you know. And we see that PO2 was, as I told you, lower than 30. Somebody has 19. And however, you could look at PCO2, and you see that PCO2 is in the teens, 12, 15. Bicarbonate is very low, obviously. But most of everything is that the hemoglobin concentration was 20 grams per 100 milliliters of blood, while our patients, the recommended hemoglobin content of our patients is 7 grams per 100 milliliters. So it just shows that it's not that we can live well with 30 millimeters mercury PO2. We can survive 30 millimeters of mercury PO2, provided certain conditions. Alkalosis to shift the oxygen hemoglobin curve, pH, alkalosis is the same thing, lot of hemoglobin. Oxygen content is the most important part, which is not in this page, but in this page. If you look at arterial oxygen content, you see that the arterial oxygen content at 7,000 meters is almost normal. So, point is, our patients are not athletes, mountaineers in Mount Everest. But anyway, we have to evaluate the weight of oxygenation impairment, and the first thing we do is to increase FiO2. And increasing FiO2 has its own risk, beside oxygen toxicity, which we could discuss a full day about oxygen toxicity. But high oxygen concentration favors lung collapse, favors collapse of the low VAQ ratio regions of the lung. Low ventilation with high oxygen becomes lung collapse. And that has been done in anesthesia. And if we use 40% oxygen, immediately post-induction, our patient loses muscle tones, and we get atelectasis at the bottom of the lung, you see? Then we do a recruitment maneuver, and the atelectasis goes away, and after 45 minutes, still we have a fully expanded lung. But if we use 100% oxygen, first of all, atelectasis is bigger. We do a recruitment maneuver, and that atelectasis goes away, but after 5 minutes, it's back. Because when blood flow takes out from the lung more gas than we get there, the lung collapses. Except when we have some gas that is not taken away by blood flow, which is nitrogen. So the higher the oxygen concentration, the higher the atelectasis. And this is true in ARDS as an example. We have no pointers here, but we can manage. You see that the shunt increases from 20% to 23%. And if you look at real shunt, that is zero VAQ, it increases from 16 to 22%, going from baseline to 100% oxygen. Anyway, what we care for is to see PO2 going up. And you'll see PO2 going up, but you'll have more collapse. The next step that we all do, that is included, as a matter of fact, in the definition of ARDS, both the original one of Asbaugh, 1967, if I'm correct, and in the Berlin definition of ARDS, is positive pressure. If you want to increase oxygenation, right after PO2, right after FiO2, the next step is to increase positive pressure. And as a matter of fact, we know that we can get some recruitment. We can make this collapsed lung reopen, provided we use some pressure. And this is called recruitment, as you know. And this is recruitment Toronto style. Now we have more fancy ways of doing recruitment. That is de-escalating PEEP as an example. But I think this proves the concept. This patient has 87% saturation. They do a recruitment maneuver, and then they set a PEEP of 7 after the recruitment. In time, saturation goes down because the lung collapses again. Then they redo the recruitment maneuver, PEEP 10, and now the collapse does not take place anymore. This is another patient. They've learned that you need 10 of PEEP. So they do a recruitment maneuver, go to 10 of PEEP, alas, the saturation goes down again in another patient. Then they do a recruitment maneuver, they try 12, is not enough. Then they do a recruitment maneuver, they try 15, and now the lung stays there. After a recruitment maneuver, you need PEEP to maintain PO2 up, to maintain recruitment up. So we do not, doing recruitment is not enough. A recruitment maneuver includes a selection of PEEP to prevent the recruitment. So initially, we thought that PEEP is good to recruit the lung, but this is wrong. PEEP does not recruit the lung. PEEP prevents the collapse of the recruited lung. Obviously, we know from the work of my friend Luciano Gattinoni that if you have a recruitable lung, if you have a lot of recruitable lung, you have a very diseased patient. But please, look at it from the other point of view. If you can recruit the lung, it's because it is collapsed. More recruitable means that you have a lot of collapsed lung. So it's clear that if you have a lot of collapsed lung, you have a more diseased patient than in general than a patient that has a very small recruitable lung. So recruiting the lung, up to now, recruiting the lung is a good thing, we think. Perhaps. We'll discuss that. Because really, we have very few information about whether a recruited lung besides giving you a better PO2, means a better healing lung than a collapsed lung. If you have if your patient, let's say, has a lobar pneumonia, that lobar pneumonia does not get recruited usually. You do not intubate and apply positive pressure to a patient with a simple lobar pneumonia. But if the pneumonia includes 3 lobes, then you attempt recruiting. But lobar pneumonia heals, if the patient survives, lobar pneumonia heals perfectly, according to the agent. But anyway, in general, pneumococcal pneumonia heals perfectly without recruitment, provided you can recruit. Another important point is mean airway pressure. As an example, if you use pressure control, mean airway pressure for the same peak pressure is higher than volume control. And that, I think, is one of the reasons why often pressure control gives you a better PO2 than volume control. But what is this to do here? Oh yes, airplanes and war. This is a paper from 1938, before Pearl Harbor. And it shows you that if you apply positive pressure, you improve oxygenation. Also, in patients with pulmonary edema or lung collapse. Because what has the airplane to do with it? That they did not have pressurized cabins, so they have to breathe oxygen at positive pressure. And positive pressure improved oxygenation at high altitude. So the main difference between controlled, should we call it traditional control mechanical ventilation and high-frequency oscillation is that high-frequency oscillation is used with a very high mean airway pressure in the 30s. Your patient, a very severe ARDS patient, so severe that is candidate for ECMO, normally, very rarely has a mean airway pressure higher than 24, 25. HFO runs at a mean airway pressure higher than 25. In the 2 major studies about HFO, mean airway pressure was around 29, if I'm not wrong. So this is a very well-known mechanism, but it has effects, side effects. aprv is the same story. aprv is ventilating at very high mean airway pressure. Like in the old days, we had inverted ratio ventilation, 4:1. We've even seen applying inverted ratio ventilation with controlled volume control ventilation, which is very dangerous. Don't do that. You might be seeing good PO2s, but dead patients. If you do inverted ratio ventilation, you can do it only in pressure control, because volume control in inverted ratio ventilation is not safe. But the key point is always, I think, mean airway pressure. What is this? No, this is the oxygenation depends on the cardiovascular system too, not just the lung. And if you have a hole between the right and the left lung, and you increase the pressure on the right side, the flow of blood will go from the right side to the left side of the heart. And you'll have an extra pulmonary shunt. This is a work from Paris, Professor Dessapp. It shows that in patients with high intrapulmonary shunt, increasing increasing PEEP actually increases the shunt. So it's not true that increasing PEEP always increases oxygenation. One of the reasons might be intracardiac shunt. In this study, the prevalence of shunt was some 15%, which is not a small percentage of our patients. So keep in mind that the heart is of some importance in determining oxygenation. If you really want, you can try nitric oxide. It works for a short period most of the times. It decreases pulmonary artery pressure in different amounts, and it increases oxygenation in different amounts. The mechanism is that nitric oxide, as you probably know, increases the flow in ventilated regions, decreasing the proportion of blood flow that goes to collapsed areas. So the oxygenation might improve. In the long term, though, survival is in general not affected by the use of nitric oxide. Another thing you can do if you have a severe ARDS patient with a low PO2 is to use neuromuscular blocking agents. Is a recommended maneuver during the first 48 hours with severe ARDS patients. This, by the way, it increases oxygenation most of the times, but moreover, it increases survival. I want to make the concept that oxygenation and survival do not always go together. In this case, they go together, because you can increase oxygenation and decrease survival. Here, you increase oxygenation and increase survival too. Pruning? Pruning is a very old story. This is one of the first papers of pruning in adults, 1988, once again from the group of Luciano Gattinoni. It shows that PO2 increases pruning patients, and it increases survival too. The two things are not connected. My colleagues always tell me, often tell me, we prune the patient, PO2 did not increase, so we should not prune him anymore. But survival in pruning is not necessarily linked to an improvement in oxygenation. The reason by which pruning increases survival is not simply oxygenation. There is, as you know, selective recruitment of the dorsal regions of the lung when we put a patient prone in general. And this is an advantage because the amount of collapsed lung for the same pressure gradient is decreased in prone position, simply because of the shape of the lung. We have in supine position, we have only 38% of the lung on the top region. But if we put the patient prone, the top region becomes much bigger, 57% in average. By converse, the collapsed region becomes smaller. So pruning gets the lung more homogeneously ventilated, with less hyperinflation, with less pressure. John Marini showed that you can maintain the lung recruited at a lower pressure in a prone patient compared to the pressure you need to maintain the lung recruited in patient, pig actually, in supine position. So ventilator-induced lung injury-wise, pruning is much more effective and cheap than using positive pressure. Because for the same positive pressure, you have more ventilated lung and more homogeneously ventilated lung. At the end, when you have tried everything, you can use ECMO. And I do not have to explain what ECMO is, I guess, right? But why is ECMO effective in increasing oxygenation? That ECMO increases oxygenation because of simple physiology. Look here, you have a patient that has 50% oxygen saturation, mixed venous oxygen saturation. Obviously, he's a disease patient. It has 50% mixed venous oxygen saturation, 50% shunt, half of the lung is not ventilated, half of the blood gets oxygenated by the good lung, the other half does not get oxygenated, so the average saturation in the artery is 75%. Is that understood? Should I go back to that? No. PO2 is 40. Now you apply ECMO, and mixed venous saturation goes up to 75 or 80% because you oxygenate venous blood in VV ECMO. You oxygenate venous blood. Mixed venous saturation goes up. Now you mix 75% with 100%, you get to 87% saturation. Nothing has changed. The lung is the same, but mixed venous saturation has gone up. And now PO2 is 60. And you rest. Rest peacefully is not good, right? You rest thinking about a good day next day. You can couple pruning with ECMO and further increase oxygenation. But then we go back to the usual question. Should we correct hypoxemia? Should we do all these invasive things to correct hypoxemia? As always in ICU, you have to make a compromise between what you pay, actually your patient pays, and what you get. Because low oxygen causes, apparently is linked, not causes, is linked to anatomical damage of the brain, like in this paper. And moreover, in this, from Mikkelsen, comparing a PO2 of 86 with an average PO2 of 71 changes the cognitive function of ARDS survivors. And I would not consider 71 average PO2 very low. So we actually should be careful in targeting our PO2s. In the lung safe, Giacomo Bellani showed that in average, in mild ARDS, people apply 7.4 centimeters of water to a saturation of 97%, moderate 8.3 centimeters of water to a saturation of 95%. But when the patient is really sick, severe ARDS, they are happy with a saturation of 90 and a PEEP of 10. Our conclusion is that a PEEP of 10 is kind of lowish for a severe ARDS. But 90 of saturation is not that dangerous, probably. So, well, perhaps we could recommend a slightly higher PEEP. But this is the wisdom of the people. Look here, this is the low VT, low tidal volume against high tidal volume 17 years ago. And you know that low tidal volume survives more than high tidal volume. But the PO2 of the low tidal volume was lower than the PO2 of the high tidal volume. So once again, higher PO2 does not mean better survival. It depends on what you pay for it. And this is one of my last slides. You see that this is our colleagues, Palle Palmen from Stockholm. Patients on ECMO, before cannulation, the average airway pressure was 25 centimeters of water, mean airway pressure in his patients. After cannulation, he went down to 10. It means that PEEP was 5. But now, you know, this is done to decrease ventilator-induced lung injury. Decrease pressure is the best thing to do to decrease ventilator-induced lung injury. Mainly mean airway pressure. But look, before cannulation, saturation was 85%. In ECMO, saturation was 80%. What did he do? He traded a lower oxygenation for much better ventilation, lower risk ventilation. He could not have gone to these pressures without ECMO. His target was not to correct hypoxemia, but to spend less to get the same oxygenation. Your patient does not need 150 of PO2. Perhaps this is a kind of extreme solution. My patients are not like this. I like PO2s to be a little higher. I don't know whether I am right, but Palmer has a very good survival rate. Moreover, keep in mind that hyperoxemia is bad. In many situations, hyperoxemia increases death rate. And Girardes in Modena showed that his survival is much better in ICU patients if you aim for a saturation between 94 and 98% rather than a saturation between 97 and 100%. And by that, I think I'm finished. Supranormal values of PO2 are not good. Be happy with saturation between 87 and 97 and make a compromise between what you pay, pressures mainly, and what you get, PO2s. In this, ECMO helps because it increases mixed venous saturation and allows decreasing pressures. Thank you.